Dr. Krishnaprasad Kudlu has to leave, and so he will be speaking about intraoperative complications of SMILE. This will be the first talk. Over to Dr. Krishnaprasad.
Thank you so much, Dr. Sai, and I thank Srini for this opportunity. So I'll be straight away talking about the video presentation of SMILE. I think when you start with the SMILE, always being a doctor myself, I talk to the patient how exactly he has to behave on the table, and optimal application of the anesthetic drop is also very, very important. Put a drop of anesthesia, so that don't put excess drop of anesthesia, so that it will loosen the epithelium. Normally patient parameters has to be checked by the surgeon himself, because you have to be double sure that what you are doing is correct. Once you double check the power, then you can go ahead with the calibration for that particular patient. Then proper draping and application of the speculum is also very, very important, because you need to have a very widened space also. Once put the proper speculum, then adequate wash of the ocular surface and the fornices is very, very important. Make sure that there will not be any debris over the cornea. Make sure that conjunctiva is dry and cornea is semi-moist. Head positioning of each patient in refractive surgery is very, very important. Make sure that you turn towards the opposite side whenever patient is having a longer nose. Be careful about even patients with a longer hair. Connecting and selecting the appropriate cone is very important. For right eye, hold the cone in the right hand, and then go to the slot and lift a bit. Then you will hear a click noise. That time machine will start calibrating for that particular cone. This is very, very important. Patient with the white to white lesser than 12 mm, go for small cone. 80 to 90% appellation is sufficient. Patient with the white to white more than 12 mm always should go for 100% appellation. The treatment starts with the lenticule cut, then followed by the side cut, then with the cap cut, then with the incision of 4 mm initially. Then you can reduce the incision size also. So now get back the patient under the microscope. Now identification of the right plane is very, very important. First you identify the anterior plane. Now I am identifying the posterior plane and then keep it ready. Now I turn the dissector, go to the anterior plane properly, try to dissect it, something called a windshield wiper movement. So dissect the anterior plane perfectly. Then once it is done, now I am going underneath the posterior plane. Try to dissect both the plane equally. Make sure that lenticule will not be folded. Once your dissection is perfect, both anterior and posterior plane, then removal of the lenticule is as simple. It will come out easily, and put it over the cornea to see for the integrity of the lenticule. So I will be just showing you the common complications of SMILE. So all procedures will have a complications. So suction loss is one of the complication I think everybody will be scared of. If you keep the cornea most moist and conjunctiva also most moist, this can happen even in the anxiety patient. You have to be very careful. So if there is a suction loss, not to become panic, you could able to see in the video that the suction loss happens. Suction loss during the lenticule cut, you can convert into femtolasic in that moment, those are having excimer system with them. If the suction loss happened during the other step like side cut, cap cut and incision, go back to the machine, reduce the diameter by 0.5. You can once again continue with the treatment. The machine will start even doing the treatment in the same plane. So you can do the recentration, you can clear the bubbles underneath the center of the cornea and also contact lens, then you can immediately redock it and machine will do the treatment in the same plane. So there is nothing to become panic, you can go ahead with that. The one more tricky situation in SMILE I want to show is retained lenticule in the interface. The treatment is done perfectly by the machine, absolutely there is no problem. So I have trained more than 100 doctors in and around the world with this. I've seen most of the all complication with a smile. Still every case I could able to do you come back with the good results. You can see here identification of the layer done really with the surgeon, but while he is dissecting, suddenly he took out his dissector and went to the posterior plane in between. Even in the microscope on the monitor, I could able to see the torn lenticule. I told him to remove the lenticule. I told him it is not done it properly, but he was very confident. Then he put it over the cornea. He could able to see only half the lenticule is there, half is there, still not there. Then I took over the case, put this lenticule in the conjunctival sac. Then I focused the microscope. I could able to see first off inferiorly the whole lenticule is adherent to the cap. Not to become panic, go underneath with a longer dissector. Sometimes those are not sure, they can even use the triamcinolone acetate to stain this lenticule so that you can dissect it well. Then go with the microforceps, you hold this lenticule, then try to take out and put it over the cornea. So then I pull the remaining lenticule in the conjunctival sac, try to join it, now it's perfect, so my treatment is went on really well. So this is the complication I am showing you. So how to avoid? I think you have to be very, very careful when you are operating, keep your mind cool. So the last complication I am just showing you. Sorry. This is a case of actually lenticule got sticking onto the cap. Surgeon was initially known the dissection was perfect, but he could not able to dissect it properly. But then I took over this case. I started scratching the anterior part of the cap. Then I could able to separate which is sticking onto the cap and try to dissect this lenticule from the cap. Once again, it's very easy. If the machine does a good treatment, you need not have to become panic. Rather, keep your mind cool, you can take out the lenticule. So initially, first 50 cases, you can expect some sort of complication, but once you become the best, I think you can do the ultimate procedure. So always when you're doing this, anterior plane has to be dissected completely first, then posterior layer dissected. You always try to avoid multiple entries into the interface. This is the one last complication I'm showing, black spots. This yesterday Vanati also showing, this is a nightmare. If you keep your cornea too dry, you could able to come out with this type of complication. So always these are the untreated areas. So normally surgeon will have a very difficult time whenever he wants to really see for the layers. You'll have a tougher area or tight dissection. So how to manage? So identify the plane correctly, more gentle and from tissue by tissue dissection. So all this area, wherever the black spots are there, you may find little difficulty in dissection, not to become panic, rather dissect it properly so that you will come out with a good results. So all this, if you have got a more like black spots, then better to abandon the case and plan for even surface ablation in the coming days. So you have got all options whenever there is a complication in the smile. So make sure that hand-eye coordination and doctor experience really makes a sense. If black spots are extensive, then I can go for PRK. So thank you so much. Once again, I thank the Kerala Ophthalmological Society given this opportunity. A lot of students are also joining in my place for postgraduates. Once again, I get to see more and more people. Thank you one and all.
Thank you so much, Dr. Kudlu. While Dr. Partho gets ready for his next talk, I've got one quick, simple question. Which are the cases where you wouldn't do, or which are the cases where the smile can be done where a routine LASIK cannot be done?
Yeah, especially when I'm treating for a high refractory error. If it is more than 5 diopters, then normally my first preference will be smile only. Because the amount of tissue loss, and also if you keep the cap on the very thinner side, then the tissue saving will be more in smile compared to the other conventional LASIK.